Thank you so much. My name is Joy Phumaphi. I am a board member of Medicines for Malaria Venture, and it is a privilege and an honor to welcome you here today on behalf of the co-hosts of this wonderful event. As you are aware, when we developed the SDGs, the African continent took a decision that they were going to keep their eye on the ball and aim at malaria elimination. Now we know that we are only 4 years away, if we are lucky, and it's not likely that they are going to receive this wonderful gift of elimination. But it is possible that with an extra big push by all of us, ministers, communities, heads of state, you, the partners, researchers, innovators, we will be very close to getting there, or at the very least, a critical mass of countries will be there. So today we are going to talk about one accelerator of this process. And this accelerator is innovative medicines. We are going to talk about what are the challenges, the options that are available to us that we can pursue in order to reach that golden gate. So first of all, I would like to welcome my minister, my neighbor minister, Minister of the Republic of Zimbabwe. You are welcome, together with your delegation. So the way in which we are going to be running this event, Honorable Minister and Honorable Minister, is that we are going to try very, very much to keep to the timelines that we have been given, because we want everybody to have an opportunity to speak. But we have English and French translation here, so please use it if you cannot speak either of the two languages. We also recommend that you keep your mobile phones open, because we are going to ask for your opinions using a Mentimeter. So in order to set the tone for this meeting, in order for us to see indeed how we are going to save this baby and the other 1,200 babies that we are losing every day, believe it or not, I have the privilege and the honor of introducing Dr. Michael Charles to set the tone for us.
Thank you. Oof, I'm charged. Thank you, Joy. Your Excellencies, it's a great pleasure and honor to be able to set the tone and address you today. Allow me to be slightly provocative. We've been talking about malaria control, malaria elimination since I was in my mother's womb, and that was a long time ago. And we're still talking about it today. And the question is, what else can we do to ensure we accelerate progress? As Joy rightly said, we are losing over 1,200, mainly children under the age of 5, mainly on the African continent, every single day. We're in the 21st century, and I think you'll all agree with me that that is unacceptable. So we need to start thinking through what can we do differently. From the RBM partnership perspective, and together with many of you, We have been thinking through what we could do, and one of the things that we've seen, again to be provocative, is we're fragmented. And as long as fragmentation exists, we will not be able to reach our end goal. Coordination is lacking because we have different agendas, different egos, different objectives. We need to bring all that together for the benefits of the babies that we need to save, for the benefit of the pregnant woman that we need to save. How are we using data? How are we using surveillance? I was talking to the Minister of Health of Sierra Leone the other day, and he said, generally we talk about data as if data is static. But he told me that what he wants to know is who is dying, why are they dying? Did they take any medication before they died? How long did they take before they came to the health facility? Those are the questions we need to ask ourselves to be able to then have responses that are very targeted. We talk a lot about subnational tailoring. Those are the things we need to do to ensure that we're using the resources that we have, that is not even enough, to be able to reach the people that need it the most. Innovation is something else that is also quite important. Innovation in terms of vaccines, in terms of new medication, and really this is to congratulate MMV for Coatem Baby that has just been on the market, which was never there before, but it's a medicine that's used for children or babies beneath the weight of 4.5 kilograms to treat them. We have products like tafenoquine. Again, this is a great innovation that has been developed, used for Plasmodium vivax, which has totally changed the course of having a 14-day course to a single dose treatment. These are the kind of innovations that we want, and these are the kind of things that we believe will be able to accelerate our work towards ending malaria. Allow me to quote a minister when we're talking about innovations. And the minister of Brazil said 2 days ago in another session, he said, and I quote, "Innovation without access is not innovation. Innovation without access is injustice. Innovation must be accessible, equitable, and sustainable." Yesterday, we convened a dialogue with many stakeholders, donors, investors, private sector, to really talk about innovation and what it takes for us to move to the next level. There is fragmentation. We are too slow. Pre-qualification is not fast enough. And the longer we wait, the more babies will unfortunately die. So for me, really, this is a cause to action that we all need everybody to be on the same page. We all need you to walk the talk. We need action. We've spoken enough. The more we speak without action, the more babies are dying. Again, it is really unacceptable that in our lifetime we're still having 1,200 people die every day due to a disease that is preventable, treatable, and curable. I hope that we don't come here next year again and say the same thing over and over again. They say the definition of insanity is doing the same thing over and over again and expecting a different result. We are committed to doing things differently, and I'm sure you are all committed to doing things differently. Allow me to end with a quote from Madiba, Nelson Mandela. "It's always impossible until it's done." I believe it can be done. Zero malaria starts with me. Zero malaria starts with you. Zero malaria starts with all of us. Thank you very much.
Thank you. Dr. Michael Charles is the CEO of the RBM Partnership to End Malaria. So he's responsible for coordinating all of us. So when he says we have to go far, I think the ministers are going to ask, okay, we are going far, but how do we get there? And so we want to ask the ministers, what is your vision on malaria elimination in Africa? Particularly when you are coming from a high-burden country like Mali, Honorable Minister. What is your vision? And when you talk about going far, he's talking about the length of time, distance, lives, resources, investments that you'll have to put in order to get there. So, Honorable Minister, if you'd like to come to the lectern, can you please come and share your vision with us?
Je vous remercie tous. Je vous remercie tous et nul n'est sans savoir que le paludisme constitue vraiment un problème de santé publique en Afrique et ça constitue l'affection parasitaire la plus meurtrière sur le continent. Et dans la zone Afrique de l'OMS, c'est la zone la plus touchée. En 2024, on avait plus de 94% des cas et 95% des décès dans le monde. Et 75% de ces décès dans la région touchaient des enfants de moins de 5 ans, avec en tout 11 pays qui supportent les 2/3 de la charge, dont malheureusement mon pays, le Mali. On peut dire que durant ces 2 dernières décennies, il y a eu beaucoup de progrès notoires, mais 2030, c'est très vite arrivé. Nous sommes déjà en 2026 et pratiquement au mois de mai. Donc, si on est debout, on doit marcher. Et si on marche, on doit courir pour arriver à 2030. Donc, en ce qui concerne les progrès vers l'élimination, vous savez, il y a non seulement les gouvernements, mais aussi la communauté internationale. On doit se donner la main, se mobiliser pour accroître les ressources aussi bien externes qu'internes, pour mieux financer les interventions en lien avec la prévention et la prise en charge. Parce que tout commence par là. Par rapport à la menace, par rapport à la prévention et à la prise en charge, nous avons vu que présentement, il y a l'émergence de la résistance des vecteurs à certains insecticides. C'est-à-dire avant, si les vecteurs étaient automatiquement tués par certains insecticides, on commence à voir de plus en plus qu'il y a de la résistance. Notamment, et des parasites aussi, notamment les dérivés de l'artémisine qui sont utilisés fréquemment dans nos pays. Il faut noter aussi qu'il y a l'émergence de nouveaux types de vecteurs qui sont là. Et ça aussi, c'est une autre menace pour notre système de santé. Mais Dieu merci, nous avons des moustiquaires de nouvelle génération et des nouvelles CTA. Mais cependant, nos gouvernements, en collaboration avec les institutions de recherche et nos partenaires, doivent s'investir davantage dans la recherche de nouveaux médicaments et d'insecticides efficaces pour lutter. Je remercie ici EDCTP3, par exemple, qui finance actuellement les projets de recherche sur le vaccin R21, dont les chercheurs maliens sont partie prenante avec notre ministère de la Santé. Un second point, nous avons aussi le suivi et la qualité des données de routine et leur analyse par les acteurs à tous les niveaux, parce qu'il faudra, on fait tout ça, il faudra pour mieux orienter les décisions, c'est très important qu'on ait des données fiables et qui soient bien analysées. Et un troisième maillon aussi, il faut dire qu'il faut une large couverture en santé communautaire. La santé communautaire qui est à la base de la santé chez nous, afin d'améliorer l'accessibilité des populations aux services de qualité. Et on doit aussi, nos deux États doivent aussi beaucoup s'investir dans la promotion de la santé pour une meilleure appropriation des stratégies de lutte communautaire du paludisme. Parce que beaucoup, on en parle, mais parfois on pense qu'il y a un déficit de communication et les gens ne sont pas suffisamment informés. Quand faire quoi et comment. Donc il faut avoir des gestes, il faut avoir des réflexes. Dès qu'il y a ça, l'enfant a un peu de fièvre, paf, là je dois me faire ça. Ça dépasse cette étape, je dois faire ça. Donc en ce point, pour faciliter beaucoup de choses, nous on propose le Mali, on propose d'intégrer aussi le changement climatique dans les stratégies de lutte contre le paludisme. Nous avons vu qu'il y a ces quelques années, nous avons beaucoup d'inondations, la pluie vient plus tôt que prévu, et tout le monde sait qu'avec la stagnation des eaux de pluie, avec tout, tant que ce n'est pas intégré parfois, le palud peut venir un peu. Optimiser et aussi pérenniser tout ce qui est digitalisation. Et on s'en réjouit, nous sommes là-dessus, nous avons beaucoup de structures déjà qui sont 100% digitalisées, mais c'est en cours. C'est très important pour que ça puisse nous faire aussi avancer. Et on a aussi besoin d'utiliser les résultats de la recherche. Parce que généralement, quand on a tous ces résultats, il faut parfois il faut que la population soit informée. Un homme averti en vaut deux. Donc c'est très important quand on fait des recherches qu'il y ait toujours le feedback, qu'il y ait le retour aux populations qu'ils comprennent. Et nous avons, nos campagnes de vaccination, les campagnes de distribution de moustiquaires, c'est à des périodes. Tout le monde sait que le palud, c'est à partir du mois juin, juillet. Il faut qu'on soit prêt pour ça. Et pour ça, ce n'est pas une seule personne qui peut être prête. Il faut qu'on se donne la main. Que ce soit la communauté, les individus, les États et les partenaires qui viennent nous aider. Et je pense qu'avec tout ça, il y a beaucoup de choses qui pourront être faites. Et en fait, quand on parle un peu de tout ce qui est palud, le ralentissement, c'est dû à beaucoup de facteurs. Ce n'est pas venu tout seul. Nous avons d'abord eu la réduction progressive de tout ce qui est financement internationaux. On n'en avait pas beaucoup. Et le peu qu'on avait aussi, ça a été diminué. Vu chez nous la situation sécuritaire, nous avons aussi une faible mobilisation de tout ce qui est ressources intérieures. Donc les deux faisant, c'est un lourd tribut pour nous. Et j'ai parlé aussi. Et la faible collaboration, parfois multisectorielle. Et on est en train d'aller de plus en plus vers le One Health, c'est-à-dire associer les autres ministères. Mais tout ça aussi, ça a des coûts. Parce que chacun, à son niveau, doit élaborer des projets. Mais Dieu merci, on a des programmes qui sont faits là pour ça. Bon, et le lourd poids du financement des soins. Quand on parle du lourd poids, un monsieur qui travaille, qui n'a pas beaucoup, le premier enfant tombe malade, c'est la moitié du salaire qui est dedans. Le deuxième enfant tombe malade, on préfère le garder à la maison et lui donner quelques concoctions. Et quand le troisième enfant tombe malade, personne n'est soigné. Donc ça coûte vraiment pour les foyers. Donc c'est quelque chose qui est commun à tous, il faudra vraiment qu'on voit ça. Et donc, conformément aussi à tout ce qui est fait par rapport à la feuille de route de l'Union africaine pour d'ici 2030, c'est-à-dire qu'il faudra peut-être qu'on développe des stratégies de mobilisation domestique, que ce soit public ou privé, les dialogues communautaires, informer les gens, les réunions de sensibilisation et surtout de plaidoyer auprès des autorités et des investisseurs du secteur privé. Nous avons des pays où on a beaucoup de privés qui peuvent investir dans beaucoup de choses, mais parfois qui sont mal informés, ils ne savent pas qu'est-ce qu'ils peuvent faire pour les populations. Donc quand il y a des campagnes comme ça, ça peut se faire. Et renforcer surtout le leadership de tout ce qui est communautaire et mettre en place des cadres de collaboration, comme on a dit par rapport au One Health, et réorienter, comme on le dit, au moment de la période de vache maigre, il faut essayer de mettre les ressources ensemble et les orienter vers ce qui est le plus nécessaire. Peut-être qu'il y a d'autres projets que nous sommes en train de faire. Si on les orientait vers la prévention et la prise en charge du paludisme, ça pourrait diminuer. Et surtout, il y a aussi le dernier point dont je voudrais parler, c'est la collaboration transfrontalière. Vous savez, nous avons déjà, quand je soigne chez moi, quand ce n'est pas soigné chez le voisin, ça peut revenir. Dire que le moustique, la maladie, eux, ne connaissent pas de frontières. Donc cette collaboration, je pense qu'au niveau du Mali, avec le Burkina et le Niger, il y a déjà ça qui est là. Et on essaie de faire de telle sorte que cette collaboration transfrontalière soit faite et la prise en charge aussi. Donc c'est très important. Et là aussi, c'est la remontée des données pour savoir quand est-ce qu'il y a un pic quelque part. Voilà. Donc, étant la première cause de morbidité et de mortalité dans nos pays, je pense que c'est une priorité nationale. C'est une priorité nationale, mais l'État seul ne peut pas. Et comme je l'ai dit, c'est la synergie d'action, non seulement de l'État, la population, et surtout des partenaires qui nous aident. Donc c'est pour cela qu'on a besoin parfois de l'accompagnement des uns et des autres et qu'on fasse ensemble des politiques ensemble. Parce que généralement, qu'est-ce qu'on a vu avec les partenaires? Ils viennent parfois avec des projets. Et chez nous, on dit, si tu fais quelque chose pour moi, sans moi, ça veut dire que tu le fais contre moi. Donc c'est très important dès le début qu'on s'asseye, qu'on essaie de voir, par exemple, le paludisme, qu'est-ce qu'il faut pour la prévention? De quoi on a besoin? Et ensemble, faire tout ce travail pour le bonheur de nos populations. Je pense que c'est l'essentiel de ce que je voulais un peu expliquer, mais les questions peuvent venir s'il y a des choses à éclaircir et dire que c'est une question vraiment qui nous touche vraiment parce qu'on sait que chaque année, combien de personnes meurent, combien d'enfants, combien de femmes enceintes on perd pour cette pathologie qui est évitable. Et vivement qu'on se donne la main pour qu'en 2030, cela soit juste derrière nous et qu'on fête ça tous ensemble. Merci beaucoup.
Honorable Minister, thank you so much. And I think a very, very powerful message. We have to work with communities. We have to work together. The multi-sectoral engagement. No, the minister is saying, I'm not going to do this alone. I need all my colleagues around the table, and my country is not going to do it alone. I need the neighboring countries to work together. And this is how we are going to win this fight. Now, I'm stepping out of the agenda a little bit because I have my neighbor here, Honorable Minister from Zimbabwe, the Stone House. So, Honorable Minister, you are in a different environment. You know, we thought, oh, Zimbabwe is going to eliminate. Then climate change comes along and messes you up. Can you please say a little bit about it?
Yeah, this is unexpected, but but you know, I think this is a very important topic because malaria kills a lot of people, and in Zimbabwe, it's one of our major challenges, and usually the vulnerable groups, the children, the women, are at risk, especially pregnant women also have those challenges. We may have made progress in the past, and we're very happy because we're going towards elimination. And I think in Zimbabwe, almost 50% of our rural districts were actually experiencing no malaria. Even last year, 4 out of our 63 districts reported no cases of malaria. But in some of the areas, we've seen upsurge of cases, and we have also seen increase in deaths. There are several factors that we could actually attribute to that. In Zimbabwe in particular, we actually identified a new group of people who are now affected by the increase in the malaria cases, and those are the newly resettled farmers. During the time when they are curing their tobacco, they tend to sleep outside, and they don't use the insecticide-treated nets, and they are not sleeping in houses that have been sprayed. It's a very difficult thing to deal with because most of them, they believe they can survive. It's only after they've started falling ill, you actually identify to say, they have been sleeping outside, and what do we do? Because that's a livelihood, a source of livelihood, and to convince them, it's a bit difficult. We have also experienced quite a lot of floods and effects of climate change, where the rains have been erratic and breeding places for mosquitoes have increased. And we also think that effect of climate change is contributing to the increase in our malaria cases. How do we deal with such cases? I think one of the most important things is actually community engagement and education. People should know that you can link climate change to increase in certain disease patterns, including malaria. And people should not stop using the traditional methods like indoor residual spraying and use of insecticide-treated nets. We should actually be increasing these uses. Personally, I think we should change our approach. I think we are quick to stop some of the practices that we've been doing, especially the indoor spraying and the use of nets in areas where we think we have eliminated malaria. My take is, why don't we go for 2-3 years, even after we have not had any cases, to make sure that we have completely dealt with the area and we are sure that we will not have these cases coming up. Because what we have done in some of our areas is we have not received a case this year, then next year we are no longer spraying. And we think we have eliminated all the malaria, but that's not very possible. It's only that some cases are still within the community. Community engagement is also very, very important. In our case in Zimbabwe, community leaders carry a voice that the community respect. So when you send your technocrats into areas to try and talk to the villagers, you need to engage with the leaders in the community. Your voice will be heard if you engage what we call the chiefs and the headmen in the area, and that would help us. The other challenge that we are also seeing is when we have these climate change effects like the floods and so on, we tend to cry and look for help from, I don't know whether to call them donors or external funders, whatever it is. I think it's high time we take ownership of these cases, be prepared. So our preparedness is not up to standard. And I think that is what we must be encouraging ourselves as leaders, and to say we must put more resources in terms of mitigating against climate change, mitigating against the resistances that we are seeing, and we must also put money in research to make sure that the medicines that we are using are still fit for purpose. Because I would say we don't have enough research going on to see whether the resistance is at the larvicidal or at the insecticide, or it's at the drug that we are using for the treatment. So I think that's what I can say. Thank you.
Minister, I think you have left the ball squarely in the MMV court. Very, very clear what are the medicines, what innovation is happening there, how do we make sure that, you know, these children, the mothers, the communities, the tobacco manufacturers, those who are not sleeping under a net, they is detected early, malaria, and they get treatment early. We are now going to go into the next session, which is the panel session. And I've got a very erudite panel here. And Minister, the reason why I've asked you to stay there is that I'm going to ask you towards the end to say, you know, have this panel helped you at all, you know, with the comments that they've been making, you know, so I want you to listen very carefully to them. You are going to be the judge. Yeah, so they must be very careful about what they say. But we are also going to engage you, our friends and colleagues, and I'm going to ask somebody from MMV to come and explain the Mentimeter, and tell you exactly how much time you have to answer the question. And if you are saying none of the above, this is not a Chatham House rules. I'm going to ask who is saying none of the above so that you can tell us why. Yeah, so please come.
Okay, great. So, in fact, yes, we thought that it was a good idea for this event to allow us to interact as much as possible with this impressive panel. And we will do it through the Mentimeter, so we'll go just through the technicalities. First of all, if you have, well, you need to have your mobile phone on, first of all. If you are not on a Swiss network, you can use the Wi-Fi, but otherwise, if you are roaming or you have a Swiss mobile phone, you can go directly into this Mentimeter. So I just leave a few seconds if somebody needs to go into the Wi-Fi. Doesn't seem to be so. So we move to the next one, which is the Mentimeter. So if you flash the QR code, this will take you almost immediately into the first of the Mentimeter question. You will have probably a link, Mentimeter, you can click, and then you go into the first question. And now I will give it to you. It will be actually linked to the question that will be asked to the panel. And it is this one. What are, in your opinion, the main challenges to eliminating malaria in Africa? You will see here a few categories: resistance to treatments and other tools, lack of access to innovation, climate change. Social inequities include gender inequities or inequities vis-à-vis underserved population, women, children, and other underserved population. You have constrained funding, alignment, misalignment, domestic funding, external funding, and the others. So I see already that there is a voting. We can continue. You can have up to 3 choices if you want. I think we will wait for a few more moments. I cannot see whether there are others at this point. It doesn't seem to be the case. There is 1 or 2. 2, okay. Right, so we can ask actually the participants who voted others what kind of challenges they are thinking of. They need a microphone probably, but you need to raise your hand so that you can see.
Please don't be shy.
No, exactly.
Don't be shy. Lift up your hand. Like I say, no Chatham House rules here.
But
we have an enemy to defeat.
You are not obliged. If you want to keep a mystery, it's also okay.
No. She is losing the... No mysteries, please. Help us. What are the other challenges? Who would like a mic?
I don't see raise hand.
Okay. We have all decided to be shy.
It will remain a mystery. I apologize.
Okay. So we have some impressive results. And as you can see from the results, weak health systems has been mentioned as the leading one, followed by inequitable access and lack of investments. And lack of investment is related to both of them. And then you have both resistance and climate change. So this is what the Mentimeter is saying. And then we have got 3 very secretive people who want to fight this fight alone. So Dr. Fitchet, the CEO of MMV, I would like to ask you, are there challenges that you are particularly worried about in your area of intervention as MMV? And this can include areas that are actually inhibiting your ability to deliver effectively.
Hello, is this on? It's on. Okay, thanks very much, Joy. Excellencies, distinguished guests, ladies and gentlemen, good evening. Thank you for the question. Look, there are a lot of challenges in innovation. It's pretty much a binary game. It's very high risk, it's very expensive, and it's very complex, but it's also very necessary. And the context of this panel and this meeting is about elimination. And I think the question we first need to agree on is, can malaria be eliminated? And I think the answer is possibly. Now, we want to convert possibly to probably. And the only way to convert possibly to probably is everybody working together and doing what they do best in a coordinated way. What we do is medicines innovation for malaria, obviously, medicines for malaria venture. I think it's important to just state that medicines remain critical for malaria. In the age of vaccines, we still need medicines. Medicines treat the disease, they cure it, they prevent onward transmission, and they also protect those at risk. We'll need medicines until the last parasite is killed. I think we need to agree on that. So why can't we use the medicines we have? They're actually quite good. And in general, they're working quite well. However, there is a lot of ominous evidence that there is decreased therapeutic effect and significant genomic markers of resistance to the artemisinin class, the current gold standard of treatment, particularly in East Africa. History and biology tells us eventually the parasite will win if we stand still. We've seen that in the greater Mekong region. We saw that with chloroquine in the 80s and 90s of the last millennium. So we can't stand still with malaria. We can't just use our existing meds. We can't be complacent. Malaria is the enemy, as you said, Joy. It's a very, very crafty and wily foe. It's adapting all the time to beat the drugs that we throw against it. The only way we'll get to elimination is if we get ahead of that, if we get ahead of drug resistance. I think it's important to say, and not an overestimate, and this motivates me, is we're in an arms race. We are in an arms race against the parasite. We have to develop weapons against it before it can develop weapons against us. Its weapons are the resistance to our drugs. So what do? It's a very, very difficult question, but I believe a problem that can be surmounted. We need to develop the next generation of drugs, and we need to protect the ones we have. The next generation of drugs will need to be effective against resistant strains. They will need to be safe in vulnerable populations, such as pregnant women and young children. And they'll need to act on multiple stages of the life cycle of the parasite to prevent transmission. That's a really high bar. Oh, and they have to be very inexpensive. Oh, and they have to be radically simple. It's a very difficult challenge, but it's a challenge we can meet. And the reason I believe that we can meet it is because we're well on our way. And if I may have another minute, Joy, is that okay? We're well on our way. We're not on the finishing line, but let me give you some hope as to where we are on this journey. So in the near term, we have the first non-artemisinin antimalarial in 25 years, filed in global regulatory authorities called Ganlum, ganoplacid lumefantrine. This is an incredible drug, highly effective. It works in resistant strains, it kills resistant parasites, and has the potential to prevent onward transmission. It's truly a drug for its time. And that could possibly be available if it's approved, and we anticipate it will be approved by the second half of 27. That's next year. Then we have how we protect our existing drugs. And ganoplacide lumefantrine, which is developed by Novartis in collaboration with MMV, but another exciting product which is developed and run out of the Moru Institute with the Marubeni Corporation is for AAACT. And this is trying to protect our existing drugs by formulating them together so they'll protect each other against developing resistance. This could be available in 28, so in 2 years' time. So 2 new tools in the near term. Now, to get to elimination, however, I would argue we have to set the innovation bar even higher. And this is where I think it gets really exciting, because programs in development include single-dose cure So combinations of new antimalarials, next generation antimalarials, that will cure the disease with one dose. So mum brings the baby to the healthcare worker administers one dose, observed, that's it. The disease is cured. And that is entirely within our reach. We're in phase 2 studies working with Novartis. Then we need to think about new prevention tools. Think of lenacapavir for malaria. That's already in phase 1 development. A medicine that can potentially, from one administration, protect for a whole malaria season. Not a vaccine, a medicine. That will be inexpensive, no cold chain, and effective in all age groups. Children, adolescents, adults, migratory workers. Again, to complement the toolkit we have. So I'm cautious, as I said, Joy. I think elimination through with medicines as one of the tools is possible. Whether it's probable is if we can stand with solidarity and support funding for innovation, policies that support innovation in parallel with access.
Thank you, Martin. So you are saying elimination is possible, it can be achieved. You are developing this amazing toolbox that we are all waiting with great anticipation to introduce. But the resources, after you've introduced them, I'm going to go to the Global Fund. Your boss has already told us that you've got very shallow pockets this morning. But what are the challenges that you are particularly worried about? And do you believe malaria elimination can be achieved? Martin has just said it can.
Thank you, Joy, and thank you for the invitation. Thank you for joining this important conversation. There are multiple challenges that we are facing in the fight against malaria, and actually I couldn't make it through the Mentimeter, but I would have probably ticked all the boxes, including other. I don't know who has put the other, but I would try and guess that under that category you would have things like conflicts, migrations, perhaps things like that. So we have achieved extraordinary progress in the fight against malaria, and that needs to be said, because in a way we have demonstrated that we can achieve progress, and a few countries have been certified malaria-free, which demonstrates the point that Martin made, which is that of course we can continue to achieve progress, but that progress has stalled, is fragile, and has started to be reversed in a few countries. And that is alarming, and it is certainly keeping all of us at the Global Fund awake at night. And I'm already terrified about the numbers, the data points that are going to come our way in terms of the malaria trends last year that we don't have yet, but are probably going to be quite worrying. So we have a lot to do, and certainly we are committed to working with all of you to fight those this perfect storm that we face. But perhaps one of the things that keeps me most awake among all of those challenges out there is similar to what Martin highlighted, it's resistance. Because what do we do if the tools that we currently have in our toolbox don't work anymore? And that's really, really a daunting challenge. And it's particularly dangerous because, of course, with the perfect storm that we face, with climate change, with population displacement, with conflicts, with weak health systems, with disrupted supply chains, resistance can even go further and faster. And therefore, we need to go further and faster. And if we don't come up with new tools to fight resistance now, it will be devastating tomorrow, and it will cost much more. So investment case for investing in those new tools to be able to fight resistance today is really, really compelling. So as part of, so we need next generation malaria tools and medicines, and I'm absolutely delighted to hear that many things are in the pipeline so that we stay ahead of resistance threats. And market shaping in that space is absolutely critical to signal demand, to improve affordability, to strengthen supply security, and accelerate equitable access, which I've seen people have mentioned as critical, particularly for communities, which both ministers have highlighted as absolutely central to the fight against malaria. So the Global Fund, coming to your question, Joy, in terms of what we are doing with our partners, we are working to catalyze innovation through market shaping. And under our new next-gen market shaping approach, we are deploying market tools such as access funds and volume guarantees to de-risk early adoption, reduce price barriers, and send stronger, more predictable demand signals for priority malaria innovations. So, for example, we are building on proven models such as the New Nets project, the Nets Transition Initiative that we've been pursuing successfully to accelerate the large-scale introduction of the dual active ingredients insecticide-treated nets that have been mentioned already. And we are really building on those models to expand to other tools. So recently we have, for example, announced our investment in spatial repellents, a new exciting vector control tool that is expected to fill a critical protection gap, particularly during hours when people are not sleeping and therefore not under their bed net. Of course, any new tool needs to complement the existing tools, and you made that point very, very clear. It's not about a magic bullet, suddenly we can drop everything and start afresh with something new. Absolutely not. It is a complementary tool to the tools we already have, but hope that can help accelerate our progress. In the current grant cycle that we are supporting, we are using our access funds to support countries to introduce new medicines, allowing countries to access alternative treatments and be ahead of the resistant threat that they are facing according to their context. I'm not going to try and pronounce the name of the medicines. We are working to introduce artesunate pyronaridine and dihydroartesiminin piperacin. That's right. That's right. Woohoo! I made it. Thank you. And in the new grant cycle, so grant cycle 8, we very much aim to scale up those catalytic approaches to further support these new tools and being introduced at scale. In the countries we support. And perhaps just as to conclude and to pick up on one of the things that Dr. Charles mentioned, the risk of fragmentation, we really call upon all partners to work together on those catalytic investments, catalytic approaches, to make sure that we introduce innovation in a partnership way in line with country priorities. Thank you.
Thank you so much, Françoise. So, Martin, you developed the medicines, working with developing countries, like the Honorable Minister was saying, and with research institutions in the developing countries and researchers. And you do the market shaping. Yeah, and enabling access at country level. Thank you so much. Now, we are going to have as the second Mentimeter. Please. I think it has been explained to you how this works. So this one is going to be covering the key capacities that should be prioritized in order to achieve elimination in Africa. Okay. So we have a mandatory requirement that if you vote other, you have to speak. No more secrets, please. So can we start the voting for this one? What are the key capacities? You have got many options there. Surveillance, R&D, local manufacturing, regulatory oversight, and you can choose 3. Okay. Health workforce, R&D, those are the, oh yeah, and community engagement. R&D is going up. All right. Are we still continuing? We have less people than the last time. Okay, more are voting. There's one other. Remember the one other no secrets this time, please. Share your brilliance. We want to benefit from it. Okay, so there we are. We have a community engagement, which is absolutely important. I think the minister explained earlier on how important it is to engage the communities and to have them fully on board, even when you are introducing a new innovation or a new commodity, because if they don't accept it, then it won't work. And then you need the health workforce in order to introduce any new commodity. If you don't have a health workforce, then it won't work either. So I would really see that these are capacities that are required in order to enable access, to the R&D, and also in order for the surveillance to work more effectively, you need a really good health workforce. So I think it is very, very clear that we have selected the areas where there needs to be strong relations. But we have experts here that can actually speak to this much better than I can. And I would like to go first of all to our fearless champion of medicines on the African continent, the new director of AMA, and what we would like to know, Doctor, is which capacities should be prioritized in your view that would make a big difference, because you do understand the current environment on the African continent in particular with regards to medicines and access to medicines. So which capacities should we prioritize, please?
Thank you. I'm not sure whether my mic is...
You have to... They say it's okay. Yeah.
Okay, thank you very much. I'm actually impressed that regulatory oversight was not the top one, because I expected it to be, because a lot of the time regulators are thought of as being the barriers to innovation. And sometimes I actually believe that what stands between an innovation and a patient is the regulator. And it depends. But since it wasn't there, then maybe I don't need to be talking at all. But if I can start, if you ask me what needs to be prioritized, when I heard the question, one of the first things I thought of was research. I'm saying research because I will tell a story that I always tell. There was once where we were looking at a dispersible tablet and a product, let me say that, for one of our public health diseases, and it had got to the third phase of the trial. And a lot of the time, another thing that I say is that we need to start taking part in early phase trials. Phase 1, first in human, and not wait till phase 3 before the people who are going to use the medications get involved. A lot of the time, trials come to Africa when they are in the third phase. I know the malaria vaccine, we were fortunate enough, it came to us in phase 2. But most of the time it comes to us in phase 3. Now, this was a dispersible tablet that was supposed to be put on a spoon and given to a child who had a particular disease, I'm not going to say. Now, when we looked at the trial, which was in phase 3, the diluent for the liquid that was supposed to be used to disperse the tablet was apple juice, right? Because the tablet was not palatable. Now, in phase 3, at that point, the question for us was if even water is difficult in the remotest, in urban cities, potable water. Now, if a child is going to take a product that is supposed to be diluted with apple juice, I can assure you that the mother will not use apple juice in real life. That baby or the child is going to spit out half of the product. We are on to resistance even before we started. But that was at phase 3. If that country or the country using it in the developing world that we live in had been involved right from the beginning, we would not have got to apple juice in phase 3. So for me, we need to start taking part in early phase trial. We need to build the capacity of our clinical trial sites to be able to do early phase trials. The next one that I would say is regulatory capacity. And because that regulator was a strong regulator, they picked up that in phase 3. If it had been a weak regulator, they would not have. So that trial was stopped, did not progress until they had changed reformulated the finished product for the child to be able to use water. So for me, regulatory capacity is important, because a regulator will slow down an innovation, whether it is pre-qualified or not. But let me put it as a regulator will slow down an innovation if they do not have the capacity to review what you've given to them. So for me, the strength of the regulator is important in getting a product from innovation to the patient. Apart from the capacity of the regulator, the strong regulatory systems are what will keep a product being viable. So you have an innovation, it has just been put out. But for the innovation to continue to be sustainable, you have to have strong regulatory capacity. I remember when I talk about that, I talk about things like quality and safety monitoring. We have substandard and falsified medicines. We have pharmacovigilance. If you do not have strong systems, you will have products that will come as good products and become bad products, because one, they are not stored properly. Two, the quality is not monitored. And three, I remember one of the insecticide-treated nets that came to the country, and there was a complaint that when people slept under the nets, they started to itch and they started to. Strong systems picked that up immediately. We found out that the bed net had to be washed once before it was used. Okay, but I'm not sure it was on the label. So in reporting such active or such monitoring by a strong regulatory agency, the manufacturer then made sure that it was on the label, that wash it once before you use it. That was a good product, but it would have gone bad because there was not a strong regulator. So strong regulators, strong regulatory systems that can ensure quality, safety monitoring. And probably the last thing that I would talk about would be making sure that access is as close to the patient as possible. So local manufacturing. At the African Medicines Agency, one of the things that we've been mandated to do is to ensure local manufacturing and manufacturing capacity on the continent. And for as long as we keep waiting for products to come from outside to the patients who need them closer, we will always be the last to get innovations, or even if we get them, the ability for us, or the probability of us getting them on time would also be a problem. So for simple products that can be manufactured locally, if you have a strong regulatory system and you have manufacturers that can manufacture and regulators that can oversee the manufacture, I think that would be a plus for some of what you're doing. And the last thing I would say is that AMA's mandate is to ensure harmonization. So to ensure that the requirements for approvals are harmonized, we can have a centralized approval for some of these products, and they can be made readily available, or they can reach the markets that they should reach on time. And AMA is going to ensure that it builds a capacity to become a reference quality assurance regulator on the continent. And I'm sure when that happens, things like, I would say the simple products that AMA can step in to assure the quality of, so that it may not, I'm using my words carefully, may not require pre-qualification outside the continent, or at least can be a bridge to pre-qualification to ensure that those products are not queued for a long time and they can be purchased, or their quality can be assured on time, so that the patients get them as early as they can. I think would help in our malaria elimination. Thank you very much.
Thank you so much, Dr. Darko. This is exactly what is needed, and we are all very excited that AMA has got very capable leader now at this head. And we are really excited about this, because this is where there has been a huge stumbling block and a big barrier to access for our mothers, our children, and our communities. Dr. Makanga, as the Executive Director of the European and Developing Countries Clinical Trials Partnership, what capacities do you prioritize? Which ones are the most important in your view?
Thank you very much, and honorable ministers, ladies and gentlemen. In our view, well, we've been working in this area now for the last 23 years, and the capacities that we prioritize are threefold. First is starting with the people. Equipping the people with the right expertise so that they have the excellence in science, they understand the local priorities that need to be addressed. And here we've been talking about drug resistance. We've been talking about individuals that are most at risk that may vary in different countries and different settings, so that age-appropriate formulations may be developed. And thirdly, looking at other populations that may be at risk, like pregnant women and individuals that may have compromised immune system. And to do this, you need people that understand the disease dynamics and people that are able not only to work locally, but to tap into the international sphere, to work globally. And this is the way they get in new ideas to be able to lead. And here we are talking about scientific excellence and scientific leadership. Now, coming to research and development, you need to have the right infrastructure to carry out the research and development to develop this. And here I want to talk about, for example, in our area, we look at all phases of clinical development of the medical interventions. You need the right clinical trial platforms to be able to do this. And we are living in a time where money is scarce. You need to optimize resources, to use platforms that may be optimized to work on different diseases and understand the disease dynamics. And more to the development initially, you need to also to look out to the products that are developed need to reach the people that need them most. And here, this is where you look at the end user right at the start. And I'm glad that a lot of attention is being paid to the target product profiles. You look at the end users in mind and also what you want to achieve. Developing medications for uncomplicated malaria is different from developing medications for severe malaria. Uncomplicated malaria, you are developing medications for treatment and also medications for prevention. So understanding the product and also the delivery mechanisms for these interventions to circumvent the big problem of efficacy decay. We've had products that have been evaluated to be highly efficacious. And then when they're introduced in the health system, they plummet to 20% from 90%. So this is an area that needs to be given attention, and that's where the people, again, in the workforce have to be addressed. And allow me to speak to the other point here, and that is we have different interventions. We have treatments or drugs. We have vaccines that have been developed. And here, there has to be an understanding of the value of the vaccines. For medicines, often you use them in sick individuals or those that may not be sick for prevention. But for vaccines, you are introducing them in healthy-looking individuals. Community understanding of this is key for all this. And the ministries here have to be helpful so that the combined approaches of using drugs and vaccines are put in place. And not to forget diagnostics. And diagnostics are key, not only for surveillance, not only for diagnosis, but also when it comes to understanding. We've been talking about drug resistance here. In many cases, it is reduced efficacy, but not necessarily drug resistance. And this is where products that are developed need to be introduced in a way so that the prescription practices are addressed appropriately. We've been talking about Coartem baby, for example, that has been developed for the very small babies. It's just been registered. If it is not given appropriately, we are going to lose it. So we need to protect these new tools that come in. I'll leave it here.
Thank you so much, Dr. Makanga. I feel that you really addressed some of the concerns that the minister raised I'm not sure you actually answered fully Dr. Darko's concern about, the trials, at what stage we should come into the continent. But I'll come back to you about that. I'll come back to you. I'm going to go to a senior researcher, Dr. Fatimata Sall, and ask you the same question. Which capacities should be prioritized in your view?
Thank you. I think many of very important points have already been raised this evening. And what I would add from a researcher perspective is, based on my experience working on multiple countries in West and Central Africa, one lesson has become very clear to me. The challenge is not always access to innovation, but it's our capacity to ensure that innovation are effectively delivered, accepted, trusted, and adapted in real-world settings. So, achieving malaria elimination for me is also about being able to generate evidence that are useful for programs, that are connected to communities, and also that are adapted and translated into action. So that's why I would say, for me, there are three key areas where investment should be prioritized. Firstly, we need stronger implementation research, and that is embedded within national programs. Because having worked with 14 countries across West and Central Africa, I can say that research findings are more likely to be translated into action when programs are at the center and when research questions are country-defined. And as resources become more constrained, countries must maximize the impact of every intervention they are delivering, and that means being able to identify operational bottlenecks quickly, being able to understand why some populations are still being missed, and being able to adapt strategies based on local evidence and based on community realities. Because those communities should not be only the beneficiary of the intervention, but they should also be key actors that can help shape how interventions are designed, how they are implemented and adapted. And one example I can give from our works, from our experience, both in seasonal malaria chemoprevention and in malaria vaccines, what we repeatedly observed across countries was that coverage gaps are often linked to missed opportunities, challenges in follow-up, perceptions within communities, or difficulty to reach certain population. And those are challenges that innovation alone cannot solve. Secondly, I would say we need stronger data systems and greater use of data for action. Because in many settings, we are collecting a large amount of data every day, but they are often fragmented across multiple platforms. They are of variable quality, and they are underused for timely decision for programs. So countries need national capacity and ownership in digitalization, interoperability, in data quality and analysis, not only at central level, but even at district level, so we can ensure that evidence will continuously guide program implementation. And lastly, I would say we need to invest more intentionally on people, as it has rightly been highlighted by the previous speaker, in people, but also in institutions. Particularly the next generation of African scientists with a focus on women researchers. And because sustainable progress toward elimination cannot rely only on short-term projects or expertise, external expertise. So it requires locally driven leadership. We also need strong institutions and sustainable research ecosystems that can learn adapt and respond over time. We also need environment where African researchers can grow and contribute to solve the challenges that are affecting their own communities. So ultimately, I would just say malaria elimination will not depend only on innovation itself, but on our capacity to turn innovation into meaningful and lasting impact. Thank you.
Thank you so much. So we understand why you are a senior researcher. Yes, lots of brain power there. So we are now coming to the part where we are going to ask, you are going to ask this erudite panel some questions. So please lift up your hand either side. Whoever wants to start. And while you are still thinking of the question, I'll ask Dr. Makanga to answer the question that was that I referred to earlier on. Why can't we start with the trials from the beginning on the African continent?
Right. No, thank you. This is, and this is where it comes back again to the people, because over the last 2 decades, we've been working very systematically to develop expertise. We've supported over 3,000 senior researchers to really equip them to lead research teams and to be able to set up and progress research centers. Some of them have actually gone to the extent of establishing research centers from the scratch. And this is, I can attest to this on the continent. Now, the capacity varies across medical interventions. If I may speak to vaccines, for example, we now have facilities that are able to evaluate from phase 1 to phase 3 and post-registration. If we may talk about ARA21, M-Metrics, we were privileged to have supported it right from when it came from the preclinical, taking it through phase 1, 2, and actually the richest data that has been generated has been on the African continent because of scientific leadership on the African side. So there is capacity that is being developed. The other reason, of course, is where the product comes from. And I have to say that the trajectory changing. In South Africa now, there is the research work of Professor Kelly Kibale, who has been involved in drug discovery, going into preclinical, and the phase 1, phase 2 work is going on. On the monoclonal antibodies, I have to say that we are supporting work where the product is derived from the patients in Africa, for example, in KwaZulu-Natal, contributing to the purification of these and evaluation of these products. We have some that are now in phase 2B. So this work is happening, but of course, it happens in phases, in stages, and different countries.
Thank you. And I would really like to thank Dr. Darko for raising this issue, because DG, at your level, it is important that you make that message clear. Yeah, so that all our partners work like Dr. Makanga is saying, to develop that local capacity so that we get where we need to go. And I think there is no question that the technical capacity is there. It just needs to be trained so that they can gain the experience to be able to do it. And I think Dr. Fatimata is an example. I mean, she's absolutely impressive. I'm told that we have a country that would like to speak, Zambia. My other neighbor, Muribuanj. Zambia? Well, I don't see Zambia. And I was told that UNICEF also had a very useful contribution they would like to make. I think everybody is very happy with what this panel has just shared with us. And so I'm going to turn to the panel itself to make just one concluding remark. Please, I'm giving you 1 minute each. A concluding remark. You know, what do you want us to take away from this important meeting? And what do you think, if we had a golden key that could unlock
Joy?
what needs to be
Joy?
done, what
We
would
have-
it be?
we have
Oh,
somebody.
we have somebody here. Okay, there we go.
Thank you very much. I have, I think, a question and a practical challenge we have. We hear innovation, looking for new drugs, something coming out next year and all of that. But one of the big challenges we have is access. For example, we've had new medicines. Artesunate panaridine has been out there for a long time. But right now, you have no countries using access. So whilst we're looking at innovation, whilst we're looking at Gamloom and all the drugs coming, what can we begin to do to ensure we don't have products which are good, but we have a problem of it getting to where it should get to? We should learn from what we are actually experiencing right now. Thank you.
Thank you so much. That's an important question. Is there any other question before we ask?
Hi there, just a quick question. Thank you to the panel. You asked a great question at the beginning, Joy, about that countries across Africa should work together. So my question to the panel is, what's stopping the different countries collaborating together and pooling that amazing effort and group? If you're one group, you'd have huge purchasing pulling power. Thank you.
Thank you. That's an important question. So I will let the panel respond to the questions. I don't want to select who should speak. I mean, sometimes it is pretty obvious, but do you want to answer any of the questions, Martin? Or you want to leave it to the...
I can go in later.
Okay, okay. Minister, the last question is really targeted towards you. How do we get all the ministers and the countries to work together?
Vous savez, je pense que c'est un sursaut qui doit être là. Et surtout que la fin, c'est très proche. 2030, c'est très proche. Et déjà que les pays sensibilisent, hein, nous, quand même au niveau du Mali, nous avons déjà des groupes de travail. Nous avons le One Health, où il y a le ministère de la Santé, le ministère de l'Agriculture, le ministère de l'Environnement, le ministère de la Pêche. Il y a beaucoup d'autres ministères qui sont ensemble et qui se regroupent régulièrement, qui valident les programmes et qui font tout. Et au niveau aussi de la zone, nous avons avec le Burkina et le Niger, on a mis aussi un groupe parce qu'on a fait un forum de la santé de ces trois pays-là et on a fait une feuille de route. Ça ressort dans ça aussi. Là aussi, nous avons créé des groupes et les différents programmes sont ensemble. Ils évaluent ensemble et ils essaient de marcher ensemble. Ce n'est pas très facile parce que je pense que malgré tous ces ministères qui sont cités, il y a un ministère qui est le plus important. Je pense que c'est le ministère des Finances. Parce que l'argent, c'est le nerf de la guerre. Sans argent, on n'ira nulle part. Même si tous les ministères se mettent ensemble, tant qu'il n'y a pas cet engagement. Et ça, c'est un plaidoyer aussi qu'on fait. On a même demandé que ce n'est pas seulement le palu, hein, c'est pratiquement toutes les pathologies. Il faudra de plus en plus que le ministère de la Santé travaille avec le ministère des Finances pour qu'on puisse avancer. Parce qu'on a beau faire des beaux textes, des projets, tout, tant qu'il n'y a pas d'argent, on n'ira nulle part. Donc, on est sur la voie. On essaie de trouver comment mettre tout ça ensemble. Et généralement, quand les partenaires sont là, ils s'intègrent dans ce système et je pense que ça, on avance. Mais il faut surtout qu'il y ait cette volonté que chacun se dise que même si c'est mettre quelque part sur un tableau 2030 moins, il reste combien de temps et dire que le compte à rebours a commencé pour que l'engagement soit encore plus fort. Merci.
Thank you so much, Minister. So, as you can see, the minister here, they are walking the talk. There is a group of countries that are working together. and they're aligning not just across the Ministry of Health, but across other ministries as well, including finance and other related sectors. But in Africa, my DG, the African Union is trying to do exactly that. First of all, there's the regional grouping, and then there is AMA, and then there is the Africa CDC, and then there are the regional economic blocks. Can you just explain this vision and how you see the countries working together using those?
Thank you very much. So for AMA is the continental agency that is going to ensure convergence and harmonization of all the regional economic blocks when needed, but they will still be working on their own, and then of all the national regulatory agencies. It will not replace any agency, but it will coordinate the work of the agency. And AMA's vision is to become the continental platform that will accelerate access to the much needed medical products, including products for malaria. And it will do so by strengthening the regulatory systems. We always say that it is not the innovation that will get to the patient, but the systems that are made available, the strong systems or the effective systems that will be put in place to ensure that the innovation reaches the patient. When I talk about a trusted continental platform, Africa doesn't lack the capacity. We have, I always say we have 9 WHO maturity level 3 countries on the continent as compared to 18 in total in the world. So we have more than half of that. We also have a network of African reliance labs that are pre-qualified by WHO or accredited by ISO. So when it comes to monitoring quality and testing for products, we have the labs on the market, on the continent. We also have regional centers of excellence, some in clinical trials, some in market authorization, some in pharmacovigilance. So the capacity is there. It is a matter of pulling them all together. And that is what the African Medicines Agency is here for. We have a treaty. Unfortunately, the AMA's work is treaty-based. We have 33 countries that have ratified the treaty. We're waiting for another, if my maths is not wrong, 22. So that's what AMA intends to be, to become that trusted continental platform with all the capacity that Africa has, and we don't lack capacity. We can become, and I'll repeat it, that platform that the partners can rely on, the donors can rely on, the commercial partners can rely on to ensure that products can get to the continent on time. Thank you.
Thank you so much. And I think to some extent you've also answered the question that was asked there about we have so many medicines that are pre-qualified, I guess, by WHO, but are not being adopted for use on the African continent, even though they could actually help, particularly when it comes to addressing some of the resistance issues that we have in malaria, because you need to start rotating the medicines. So I'm hoping that the DG has answered that question. Did anybody want to add to this before we give our concluding statements?
Just very quickly, I think the key is, at least this is where we're working with our partners, we have to build access in much earlier in the process. So as I'm talking about products that are coming out in 5-7 years' time, these transformative platforms, for example, and I'm not going to particularly talk to the example of Pirimax. That's extremely complex and long story, but I think it's exactly a fair point to make. So we think, when we're thinking about a long-acting injectable, that potentially is a new platform, right? We have to think about what will that channel be in 5 years' time, 7 years' time, however quickly we can get this out. Single-dose cure, these all have implications as to how they're used. So we're trying to work with our partners in the African continent, with communities, with opinion leaders, and with through direct research, indirect research, through studies, to understand how we will ensure that these new products are effectively and rapidly introduced into the markets that they're needed in. There's another point in access as well, and let's also not forget that the regulatory no product can be used in any country until it's approved by the national regulator, right? That's just a fact. So I really do applaud and support Mimi's efforts on continental harmonization. I think this is a big difference, as will the speed in which we can get new innovations approved at the WHO. So I also applaud the WHO's recent announcement that Ganaloom will be put through a parallel guidelines and PQ process. So I think these are all very positive aspects, but I do believe that as we move forward, we will build in those access considerations with all partners involved in those discussions to try and ensure we don't get this situation happening again.
Thank you so much, and I'm sure you have had time now to think of your closing message, the golden key you are going to give all of us, and I'm hoping that with the magic of 6 golden keys, we are going to unlock, you know, all the barriers that we are facing to malaria elimination. So, my erudite senior researcher, I'm going to start with you.
Thank you. So, my last word would be just to say, let's invest not only in new tools, but in people, in institutions, health system, and communities that can make those tools successful. So innovation is essential, but innovation achieve impacts only country has the capacity and ownership to deliver it, to adapt it, to improve it based on local realities. So this is how we can move from control to elimination. Thank you.
Thank you so much, Doctor. Thank you very much. Dr. Makanga?
Thank you very much. Since I have the opportunity with the honorable ministers in the room, one of my plea is co-investment in research and development, and co-investment in ensuring access to the products that have been proven to be safe and efficacious so that they are rolled out in the countries and they reach the people that need them most. Thank you.
Thank you so much. My DG, I'll come to you after this lady speaks because maybe you'll have a comment to make about what she says. She's a very important partner. She's the main interlocutor between the countries and the Global Fund. And so I'm going to ask Françoise.
Thanks, Joy. I'm going to keep it very, very brief. Sometimes we say if we want to go fast, we need to go alone. And if we want to go far, we need to go together. And I would say in this case, that doesn't work. We need to go fast together. Let us just do it.
All right, particularly with 6 golden keys, fast together. Martin.
Probably strange coming from MME, but medicines will not solve this problem. Medicines will not eliminate malaria. They're just one of the tools. What's needed is hopefully what's represented on this panel. It's solidarity, it's political will, it's sustained investment, and it's local and community engagement together. These are the things that will move towards elimination. Tools, medicinal tools, and procurement and everything we do will contribute to that. But to me, those are the meta factors, as I call them, that are really needed to get us to where we need to be. Thank you.
Your Excellency, DG, please.
Maybe I'll take on from where you left. You said we need to go fast together. So maybe that's what AMA stands for. 55 countries going on together. One application, one review, multiple markets. And we're going fast. You get faster access. And it's not just at the point of making the product available, but at the point of making sure that the product that is available maintains its integrity while it's on the market. Thank you.
Thank you. So, Honorable Minister, do you think they've delivered? Have they giving us messages that would be useful. Did they deliver the golden keys that we need?
Oui, je les remercie et ils ont pratiquement dit ce que je voulais dire aussi, parce que vraiment, il faut un sursaut et une solidarité internationale et qu'on aille tous ensemble et très rapidement. C'est ce qu'elle a dit et c'est ça vraiment. Et il faut que l'implication de tous, même si on a tous les médicaments, tant que la communauté n'est pas impliquée, si la communauté est impliquée, tant que les leaders ne sont pas impliqués, si les leaders sont impliqués, tant que les investisseurs, les partenaires ne sont pas impliqués, même si on a ça, même tant que les chercheurs aussi ne sont pas impliqués. Donc il faut qu'il y ait ce sursaut international et cette solidarité internationale pour l'élimination du paludisme. Et mettre déjà, à partir d'aujourd'hui, mettre au rouge qu'il nous reste 3 ans et combien de jours d'ici 2030. Et chaque fois, pour se rappeler que c'est vraiment une urgence sanitaire et que tout le monde en a besoin pour le bonheur des populations, surtout des populations les plus vulnérables. Aucun enfant ne doit mourir avant son 5e anniversaire. Aucune femme ne doit mourir de paludisme pendant qu'elle attend un enfant et qu'elle doit donner la vie pour faire plaisir. Mais ça ne doit pas être un crime. Donc, merci beaucoup.
Thank you, Minister. I could not have said it better myself. True leadership, you are putting the people first. And absolutely impressive. Now, we have been speaking today, but have not listened to our key technical agency, WHO. So WHO is going to close us off with a very strong message from my friend, Dr. Abdourahmane Diallo, Director of Program Management, WHO Afro. Please, you have the podium.
Thank you very much. Thank you, my dear sister Joy. Excellencies, partners, colleagues, distinguished delegates, good evening. It is a real honor and a real pleasure for me to be here with you today to represent Dr. Janabi, the Regional Director for Africa at WHO, and actually deliver his remarks. The remarks that I'm about to deliver are from him. But many of you in this room know that this subject is very dear to me as well. I was so happy to see Dr. Charles, the CEO of Rollback Malaria. I held that role a few years back, so I'm really happy to be here. Before I deliver Dr. Janabi's remarks, because I cannot alter those, I have to deliver them as he gave them to me, I just would like to maybe come back on a couple of things. Build from what Michael said, and do something that I used to do and ask just around the room, how old is malaria? I don't have access to Mentimeter here, but I just want to quickly see what people think. How old is malaria? Just 3 answers very quickly. Sorry? Okay, I take that. So I'll ask our senior researcher here to read just this first sentence here for everyone's benefit on the mic.
The first evidence of malaria parasites was found in mosquitoes preserved in amber from the Paleogene period that are approximately 30 million years old.
Thank you. Thank you. So 30 million years old. I used to ask that question, and this is from Wikipedia actually. I used to ask that question and people give thousands, but it's 30 million years old. The point there is a disease that is 30 million years old, that is preventable and curable, continues to outsmart us today. So it is about time for us to actually outsmart this disease. The second point that I wanted to quickly make builds from what Charles said earlier. He said over 1,000 people die every day. So I used to dramatize that figure and ask everyone to convert that into, I hate to do this, but allow me to do it, to convert this into aircrafts, the number of big jets that crash every single day. An aircraft that carries about 300 people. So Michael told us that more than 1,000 people die every day. So if you divide that, it's about 3 aircrafts crashing every day due to a disease that, again, is 30 million years old, and that is preventable and curable. I just leave you with those thoughts. And now allow me to deliver Dr. Janabi's remarks. So I'm pleased to join you for this important and timely meeting to discuss the issue on innovative medicines for accelerated malaria elimination in Africa. Let me begin by acknowledging the significant efforts that the global community has made over the last 2 decades to reduce the burden of the disease, with over 2 billion cases and close to 14 million deaths averted during this period. However, malaria still kills over 500,000 people globally every year, mostly young African children. This situation is unacceptable, especially for a disease that is preventable and curable. I think you just heard what I shared earlier. During this meeting, you heard of the convergence of multiple threats we now face, such as insecticide resistance, drug resistance, and the effects of climate change that drive up the cost of malaria elimination in an already resource-constrained environment, further limiting our chances of progress. It is clear that in order to change the current trends, save lives faster, and shorten the time to elimination, we need innovative tools that can be scaled equitably. Today, we've seen strong commitment, expanded knowledge, and more powerful tools for moving towards ending malaria as a public health threat to our continent. Past experience has shown that African countries have the leadership needed to scale up innovations and accelerate progress. The rapid uptake of artemisinin-based combination therapies, seasonal malaria chemoprevention, and more recently, malaria vaccines are clear examples. This event has shown us what is still possible when we work together to translate science into policy and policy into services that protect affected communities. WHO's Afro strategic vision for a continent free of malaria involves the implementation of regional office flagship initiatives, notably strengthening primary health care for universal health coverage, including access to innovative tools, the accelerated reduction of malaria deaths following the Yaoundé Declaration through the High Burden to High Impact Initiative, strengthening surveillance and data systems to track impact and progress, and building the capacity of national regulatory authorities through the African Vaccine Regulatory Forum, established by WHO to oversee the safety and efficacy of vaccines, therapeutics, and diagnostics in Africa. The Regional Office for Africa is also advancing the development of regional production and pooled procurement mechanism to enable strategic, coordinated purchasing. To this end, WHO Afro is playing a key role in ensuring the dissemination of innovative tools through policy dialogues, updating national strategies and guidelines, supporting the design and implementation of integrated service delivery within broader primary health care and health system services, and in generating and using quality standardized data for decision making. To ensure a unified success in these efforts, I urge all of us to commit to the following actions. Member states and partners must continue to support and invest in research and innovation for new medicines and other countermeasures to address emerging resistance, accelerate burden reduction, and save more lives faster. Member states should strengthen their regulatory capacity and ensure health system readiness for innovative malaria medicines by strengthening capacity for rapid evaluation and approval, aligning national treatment policies with global guidance, and reinforcing pharmacovigilance and resistance surveillance systems. National malaria programs should improve programmatic efficiency and demonstrate leadership in generating and using data to inform policy changes in support of more effective innovative tools and strategies. Donors and manufacturers should continue to work on market-shaping projects to increase equitable access to innovative antimalarials and facilitate their uptake, starting with the most affected communities. WHO Afro remains committed to working with member states and partners to accelerate uptake of these life-saving innovations. We need to act with urgency to end preventable death and reverse the current trends in Africa. Now we can, because we have stronger political commitment, better data, more engaged communities, and more powerful tools than ever before. Now we must, because every year we delay, 500,000 people, most of them children, die of a disease we already know how to prevent and cure. I thank you.
Thank you so much, my dear brother, Dr. Diallo. And please extend our gratitude to Dr. Janabi. Colleagues, I believe that this very, very capable panel has given you the 6 golden keys, which have been reinforced by Dr. Janabi's message. We have a lot of doors to go and unlock with those golden keys, and we have to do it fast and together. So this is the big push that all of us are going to engage in to make sure that this little child and every little child has got access to this medicine here that has been developed with all our support, that has entered the regulatory approvals with the support of AMA, that has been subjected to market shaping by the Global Fund, that has been fully researched by these partners here, making sure that it does not require apple juice for the child to be able to drink it. And that has been effectively and diligently developed by MMV and its partners. Those are our golden keys. And I would like us all to thank the panel, give them a hand. And wish every one of us, particularly MMV and all the experts here who are working on getting access for these kids, for these children, Godspeed.